So we are live. Good afternoon, everyone. I am Ada from IJCP. A very warm welcome to all participants joining us for today's CME session. We have engaging discussion lined up on two highly relevant topics in modern medicine. First one is reversing diabetes, fact, fiction, or future. A case-based exploration. Diabetes continues to be one of the most pressing health challenges of our time. Today's talk will help us separate myths from reality and explore whether diabetes reversal is a genuine possibility backed by clinical evidence and case-based insights. Second, bariatric surgery, a lasting solution for obstructive sleep apnea. Obstructive sleep apnea is not only a cause of poor sleep quality but also a serious risk factor for multiple systematic diseases. This session will shed light on how bariatric surgery can provide sustainable relief and long term health benefit in carefully selected patients. We are truly privileged to have with us two eminent speakers. The speaker is Dr. J.S. Rajkumar, sir. Let me share some of his achievements. He is chairman and chief surgeon of Rigid Hospital and founder of the Lifeline Group of Hospitals Chennai. A renowned surgeon, respected teacher, and innovator, Dr. Rajkumar sir has contributed immensely to advancing surgical care in India. And here is the another doctor, P.R. Dharmendra sir. Let me share some of his achievements. He is consulted in advanced laparoscopic bariatric and robotic surgery at the Lifeline Group of Hospitals, Chennai. With his vast expertise in minimally invasive and bariatric procedures, Dr. Dharmendra has helped transform patient care and outcomes. Without further delay, I would like to hand over the session to our first speaker, Dr. J.S. Kumar, to take us through the fascinating discussion on reversing diabetes fact, fiction, or future. So, this is over to you.
Thank you very much, Ada, Guna, and Faras. I want to start by apologizing to all of you for the delay. We had some technical glitches today. We don't know, we don't normally have. So let's go straight on. In 1995, we're talking 30 years ago, and you can see this slide. The Walter Police, the first paper came out that said, who would have thought it? An operation proves to be the most effective therapy for type 2 diabetes mellitus. In the human body, as in the world, if you control fuel resources, you influence a lot of other things. So the amount of food that goes in determines both obesity and whether somebody is going to be a diabetic. We know, for example, that in the metabolic syndrome, you have a combination of abdominal obesity with a waist size of more than 36 or 38 inches, high triglycerides, high cholesterol, high blood pressure, and high glucose. Any two or three of these we consider as metabolic syndrome. My dear doctors, you must all know that on an average, we cut off one leg every 20 seconds as part of diabetes and its vascular complications in the leg. Can you hear me? We
Yes, sir. We can hear you, sir. You go ahead, sir. We will. I will call you during question answers.
beautiful,
Let's
beautiful.
go ahead. I
So
will call you
I'll
on
go
WhatsApp
ahead.
during question.
Okay.
Yeah, go, sir. Go ahead, sir. I will call you during
So I'll
question
switch
answer.
off. I'll switch off your
receive
call
the
and I'll go ahead. Yeah.
Yeah. We will start at question answer. I will call you back.
Perfect.
Fine.
Perfect, friends. Perfect.
Okay.
So, my dear friends, every 20 seconds one leg goes. Every 30 seconds, an eye goes. Microvascular complications. Every 45 seconds, a kidney goes. Every 60 seconds, one life goes. These are the impacts of the microvascular complications of diabetes. Now, many of you, the more high flying physicians, will shout back at me and say, hey, we've got semaglutide, we've got Wegovy, we've got Monjaro, we've got Ozempic. Hold on a minute. None of these cures diabetes. All of these control diabetes beautifully. They keep patients normoglycemic. But the minute you stop any of these magic drugs, boom, the sugar is up again. On the other hand, what we're going to discuss is in metabolic surgery, a one stop shop, a single day, maybe 2 days post op, one operation, and a cure from the number one mortality disease in the world today. This is particularly important because we know that India is the diabetic capital of the world and has the maximum number of diabetes patients in the whole world. When we operate upon somebody only to make them lose weight and nothing else, then we call it bariatric surgery. When we operate upon somebody who might not be that fat but who has the cocktail that I showed you earlier, namely sugar, BP, cholesterol, abdominal obesity, triglyceride, this guy is much more likely to die of vascular complications than just a fat guy with normal metabolic parameters. Most obese people will develop abnormal metabolic parameters soon, but if they do not have it, then they're at a less risk than somebody with multiple metabolic procedures. Okay, now what procedure can we look at for somebody? Let's study the operations. In our practice, these four procedures we do. Everybody now knows what's a sleeve gastrectomy. You convert the pot-like stomach into a long tube. The SAS-J is a unique addition to the Indian practice genre where we not only do a sleeve, but we divert the food contents into the jejunum, what we call a diverted sleeve by means of a single anastomosis bypass. The lab MGB, or now which is now being called the one anastomosis gastric bypass, involves cutting off the stomach into a dead end with like a sleeve, and then bypassing that into the jejunum. And finally is the Roux-en-Y gastric bypass, which paradoxically, although it's the most complicated, was the first operation to be used for obesity, in which a small gastric pouch had a Roux-en-Y bit of jejunum attached to its end. Next one. So let's take a couple of cases. This is a 47-year-old man who for 5 years had type 2 diabetes mellitus with a HbA1c of 8.4. His height was 165, his weight was 113 kilograms, and his BMI was 41.5. He also was suffering from severe sleep apnea, which means his wife felt that she was sleeping in the highway. There was so much of sound coming from the bedroom. He was also hypertensive and he had a grade 2 fatty liver. My dear medical colleagues, we are in the era of liver transplant, and nearly 50% of livers are transplanted because of fatty liver, not because of alcohol. And a lot of these fatty livers are simply from obesity and metabolic syndrome. So you can see here that full-blown metabolic syndrome, weight, BP, sugar, fatty liver, and OSA, or obstructive sleep apnea. Where do we go from here? So we planned for a metabolic surgery. After very thorough evaluation, we do either a serum insulin or a serum C-peptide. Those patients who are already taking insulin, please check their C-peptide because you might be measuring the insulin that they are injecting, jabbing into themselves. Only the C-peptide is released when the A, B, and C chains of the insulin peptides are released, whereas the all artificial or externally administered insulins do not have the C-peptide. They have only the A and the B chains. So you can see his postprandial C-peptide moved up from a 3.3 to 4.7, which means his insulin release is actually going up after food, which means his pancreas is still alive. There are viable beta cells functioning. So we do what's called a pre-op weight loss program. Sometimes we put them on injections, sometimes on tablets, and most of the time, just a liquid diet for a minimum period of 1 week, preferably 2 weeks before surgery, so that the liver will shrink, allowing us entry into the upper part of the epigastrium. What we planned and performed was a SAS-J, which is called a single anastomosis sleeve jejunostomy, which was called by the initial players as a diverted sleeve. Let's go into it in a little more detail. So this is the video playing. Can you all see the video? No? So we're just opening up this space. That's the stomach on the left side. That's the liver. This is the stomach. This is the greater omentum. And we are working our way between the greater curve of the stomach and the greater omentum, freeing as much of the stomach as we can, going distally. You can see it's freed up to the pylorus. That's the pyloric area, and that's the first part of the duodenum. There's a tube inside the stomach, and we are now transecting the stomach. You can see a series of stapler transections, various colors. They're all technical details. I don't want you to be bothering yourselves about it, but you can see that we're going right all the way up to the uppermost part of the greater curvature, and then you have an entire tube in place. Then we lift up the jejunum and we take 160, 180 centimeters, put one arm of the stapler in there. The other arm of the stapler is going to be going into the distal part of the gastric tube. Don't worry, it's only another 30, 40 seconds, just for you to understand the magic of technology and staplers. And then we're closing that hole between, you can see this hole here, between the stomach and the jejunum. That's the gastrojejunostomy opening there. The whole operation will take, on a good day, an hour and a half, sometimes less too. And on a tough day, multiple additions, etc., it may take 2.5, 3 hours. So you can see that's the almost completed there. Everything is done. And we're now taking out the sleeve, the remnant of the stomach out. So next, that's the SAS-J, bloodless, quick, and in the last few years we've had. After 1 month, his weight came down to 101 kg from 113 and a half. His HbA1c had already started coming down because of 30 days of a low sugar, no oral hypoglycemic agents. And that is very important. The average Indian goes off oral hypoglycemic agents within 1 month. You can see at the end of 3 months was a modest 91 kilograms, a good 20 kilograms, 25 kilograms before, less than where we started. HbA1c only at 5.8, it's borderline. And fatty liver grade 1, no obstructive sleep apnea. Bang. So basically, in a gastric bypass, we form a small pouch which delays the gastric emptying. And because we bypass the intestine, it actually interferes with the absorption of nutrients. Next slide. Some patients will be eating small amounts. Eating small amounts. We can see the dramatic changes. Eating small amounts, but even those small amounts are bypassed, are being sucked up. So once we bypass it, you can see here that the food comes in here, and this red part has no contact with bile or pancreatic juice and will therefore not be functional. This blue part has only the bile and the pancreatic juice, has no food in it, again will not be functional. This common channel will of course be functional. And you'll find people losing large amounts of weight. This is of course the sleeve gastrectomy. And one of the I want you to look at this insulin resistance. How can you spot insulin resistance? Someone may be even small, skinny, but he'll have a belly. The belly is equal to insulin resistance because insulin is adiposogenic to the centripetal fat. So the visceral fat of the omentum you saw in the operation, how much there was, and the belly, you can see this sumo wrestler's belly. All these patients, all these people have increased free fatty acids, increased leptin, and a decreased adiponectin, which is a adiponectin is a healthy alternative. So that's the thing saying that in the very first one, 30 years ago, 83% of type 2 diabetic subjects became euglycemic. So does it work? Enough and more data about surgically induced remission of diabetes. Provocative yet reasonable hypothesis. How can it be that one operation can produce all these? With operative risk no greater than that for cholecystectomy in 2008. So you can imagine now, why is the risk lower? Because we all work up patients much more, we pick up leaks much quicker, we use better stapler guns, etc., to avoid complications. And this is an old concept, how patients had gastrectomy and a gastrojejunal bypass for cancer. And incidentally, the sugar went away. From there, we've now come by 2006 to looking at surgery as an effective early intervention for diabetes. Of course, there's another article, original article that we wrote about autologous stem cell therapy for diabetes, this being an exciting new frontier. Young man who had a bypass at a very early age, at 19 or 20, because his father had died of the complications of diabetes, and his mother was very keen that I should do him, and this is what he became, and of course, lost his pre-diabetic status too. So you can see medical initial versus medical final. It's not statistically significant, but surgical initial versus surgical final. There's such a huge statistically significant difference about remission from diabetes and hypertension, and you'll find lots of changes like this everywhere. And you can see that the important thing is the insulin, the level of the insulin comes down, and the C peptide comes down, HbA1c comes down, and the fasting plasma glucose, all these come down. Friends, those of you who are inclined to be endocrinological, you can see here that there's a huge array of hormones like leptin, insulin, of course, ghrelin, resistin, adiponectin, PYY336, and now GIP, and there's gastric inhibitory peptide, and GLP-1, all these functioning. Patient who came from abroad, and this is what it looks like. And the story goes on and on. So if you look at diabetes, you can find, if you look at, let's say, a bypass, 93%, my dear friends, 93% undergo resolution or massive improvement of diabetes. I'm talking about from injections of insulin to tablets. Please look at the second line, complete resolution of diabetes. Complete resolution in 83.7%, which is very high. Hypertension, complete resolution in nearly 70%. Obstructive sleep apnea, improved in 95%. Completely resolved in 80%. I find in our experience, we still have to write this up, but obstructive sleep apnea is the first symptom and disease to be ameliorated in obese Indian patients undergoing this surgery, because it seems that the neck fat, which causes the laryngeal partial obstruction, goes away very quickly in Indian patients. And you can see 97% of people improve their hyperlipidemia. So this is as good as it gets, really. Various other studies, and all these things work only by something called incretins or internal insulin-like secretions. So incretins, you have either foregut theory or hindgut theory for this, and these are the incretins. They're the gut hormones that are released after eating that influence glucose-dependent insulin secretion. So here we go. GLP-1 and GIP are the two main incretins that all of you, this first talked about by surgeons 20 years ago, and it's the same GLP-1 plus GIP that works in Mounjaro, and the GLP-1 alone works in Ozempic. So basically, I'm just not going to drag this on too much, but we cause beta cell sensitivity, loss of weight, and increase. It's like having a continuous Ozempic or Mounjaro infusion inside. Okay, that's what it happens. And because ghrelin is lowered because of the foregut bypass, so there's a foregut theory and a hindgut theory. But my point is, whether it's foregut or hindgut, these are hypotheses. The operation works. Ladies and gentlemen, it works. And even in the era of how permanent is this operation, if you look at evidence-based medicine, you'll find that most of them, you have 5 to 10% coming back after a period of 10 to 15 years, but for the other 95%, they remain almost permanently without any issues. So many of you may be wondering, what is the role of Ozempic versus surgery? In my mind, Mounjaro and Ozempic are here to stay. There is no doubt. For patients who've got 5, 10, up to 20 kilograms, perfect. But people who've got more than 20 kg, who have multiple metabolic issues, who have reflux or obstructive sleep apnea, these people for these people, surgery is a wonder. And in the absence of more evidence, still surgery is the primary modality for a reversal or cure of diabetes. With this, I will stop and get my illustrious colleague, Dr. Dharmendra, to speak for the second part. We have another 15, 20 minutes?
Yes, sir. Yes, sir. We have.
Right, I'm just going to start the second of the case presentations, and this will be done by Dr. Dharmendra. Very interesting about obstructive sleep apnea, which is getting very, very common in India. So I'm getting Dr. Dharmendra is now going to be doing the presentation. Makes sense for us? Ada? Great. Thank you so much. Thank you. Thank you. They just continue.
Hello, good evening, all. So, in this good evening, we will discuss. It is a continuation of what Sir has spoken. It is a whole conglomerate of metabolic syndrome. One of the issue is this obstructive sleep apnea. It is the cornerstone that is a result of insulin resistance and central obesity and the fat around the neck. So, what causes the fat around the neck? It causes the narrowing of the pharyngeal airway, repeated episodes of airflow arrest, and oxygen desaturation and sleep disruption. So, patient is getting the low quality of sleep, so which further worsens the insulin resistance, and it causes more insulin resistance and hypertension and all the parameters of metabolic syndrome. So according to apnea hypopnea index, the following has been categorized as under. See, normally this apnea hypopnea index may be less than 5 events per hour. That is normal. But in severe cases, you can get more than 30. So patient will get a daytime somnolence. So they will be sleepy. They will have a headache because of poor night sleep. So it is indirectly or directly affecting the quality of daytime performance, and further leading to insulin resistance and hypertension and metabolic syndrome. So like you can see, so here the fat deposit in the pharyngeal airway, it is causing obstruction. So it is the lateral, you can see the airways is going to hit here. So it is causing obstruction here. So the upper airway is a complaint tube. So it will collapse at times. So when you are slept deeply, and these muscles and fat, it will be flabby and it will obstruct. So either at the sub palate or at the level of tongue. See, tongue fall back also, the patient will get obstructive sleep apnea. So upper airway neuromuscular activity, including reflex activity, decreases with sleep, because we will lose the reflex. So sometimes we will get the cough also. Uh, so it is pronounced in patients with OSA. So they will have so the continuous spells of apneic spells. So they will suddenly frightened and they will get up in the bed as like they are dead. So they are afraid that much. So you can see fat deposition around the airway, and because of level of leptin is increased in obese people, and it affecting the breathing function as a result of chemoreflex mechanism. It is OSA people always they are obese. In very few patients only, maybe without this weight component, there may be OSA also. That is showing as daytime somnolence, and uh, they cannot keep active during the daytime work. So it is accompanied by potential leptin resistance and obviously insulin resistance, and there is increased ghrelin level. All anti-incretin hormones are increased, and leptin won't function in these people. So leptin, it won't function, and ghrelin is more. So they will take the hungries, they are more hungrier, and they will take more food intake and less expenditure, and they become obese. So um, in our insurance claims, there are two factors as comorbid for this metabolic surgery. One is type 2 DM, the other is OSA. These are the two uh, main comorbidities that our all insurance companies are accepting as comorbidities. You can write either OA or lumbar spondylosis or even hypertension. They won't accept. They will accept only type 2 diabetes and OSA. So you have to prove OSA by sleep study. Only with the sleep study showing severe OSA only, the insurance people approve for metabolic surgery. So obesity is nowadays reversible thanks to metabolic and bariatric surgery. So others modifying other risk factors are like alcohol, binge eating, and estrogen depletion in menopause. So obstructive sleep apnea is almost always associated with obesity, that too with central obesity. So the intervention is possible. So there is no need to work on your pharynx, but instead you work on your stomach. You control the obesity, naturally the fat will go around the neck, around the airway, and the OSA improves. There are a lot of studies here. Overweight and obesity are linked. So prevalence nowadays it is more than, it is not as a, you can see up to 58% in women also it is increasing. Nowadays we are seeing every other patient, like it is not 37, it is more than 50%. And OSA is also associated with neurocognitive dysfunction and cardiovascular disease and insulin resistance. Because of lack of proper sleep quality, they will get insulin resistance and dyslipidemia and other motor vehicle accidents. And obviously, always OSA is associated with metabolic syndrome, abdominal obesity, and glucose tolerance not even impaired. They're already type 2 diabetes and hypertension. So we cannot link, but mainly this poor sleep quality. See, you can see 70% of those with OSA are obese. Prevalence, obviously, it is more in men, but nowadays in women also we are seeing more OSA. You can see the if BMI increases, obviously OSA also increases. So obesity is the prime risk factor for the OSA. So because the distribution of fat, maybe it is central, but it is also around the neck, around the airway also. So that's why we consider weight circumference is more important than BMI. Some people they will have muscular obesity like that. They will have all around muscular, so their BMI will be more, and they are not considered as originally obese since they don't have any OSA or type 2 DM. So increased waist circumference is obviously correlating with OSA, because more central obesity people will have OSA. So these are all the like vicious circle. If you're obese, you will get OSA. If you have OSA and you are decreased physical activity, and you won't get the fire to do exercise, and you lack motivation in your work also, and you may go for depression and eventually lead to obesity. This is a vicious circle. So that's why even in 2000 itself, CPAP machine, home CPAP machine came, and it works wonder. It is just a stopgap machine before surgery. Because if you want to avoid this machine, you should go for the surgery and get rid of the obesity. Then OS is gone. Otherwise, in the meantime, if you have to use the CPAP machine, and all parameters, all everything get improved. Your hypertension will get improved. Your insulin resistance also improve because of the good sleep quality. This is the sleep study pattern. These are all their patients. So we will concentrate always weight loss in patients with OSA. Obviously, if you do surgery in above postmenopausal, the weight loss will be very less only for unknown reasons. Maybe their BMR is so low, so they cannot push more, so their weight loss is less only. So weight loss by doing bariatric or metabolic surgery is the main treatment for OSA. You can see if you greater the weight loss, and OSA resolution is also more. So OSA patients, they have always higher fasting glucose. That means glucose intolerance and more insulin levels also, and obviously their diabetic, their HbA1c levels will be always more than 8 or 9. So the severity of uh, severity of obesity or diabetes, it correlates with the OSA, that is apnea hypopnea index. So that is more correlated with central obesity. Study showed the treatment with CPAP over 4 months improved glucose metabolism and even hypertension also. So that is improved. So effect of OSA and obesity on insulin resistance were additive. So we can improve the OSA by doing surgery. So you lose weight also, and OSA will go. Then your insulin resistance will improve. Even hypertension, if you are on 2 pills, it may come down to 1 pill, because hypertension, it won't go completely, but the tablets will get reduced. So a study indicated that OSA is highly prevalent in extreme overweight adolescents meeting eligibility criteria for bariatric surgery. The significant weight loss after bariatric surgery was associated with either the resolution of OSA in majority or significant reduction in the OSA severity. These findings should be considered in assessing potential candidates for surgical weight loss. Because OSA is associated with cognitive deficits as well, and metabolic and cardiovascular morbidity, the potential positive impact of significant and sustained weight loss on the overall health of extremely overweight adolescents cannot be overemphasized. That means if you go for metabolic or bariatric surgery, obviously you will lose weight like 30 to 40 kg in the first year. But before losing that much weight, maybe after losing some 20 to 30, 25 kg, the patient won't need any CPAP machine, or patient is completely freed of OSA. So before leaving also, patient will become non-diabetic. Maybe it is happening simultaneously. Patient, the insulin sensitivity is improving. At the same time, OSA also is resolution happens. So reducing caloric intake, so it is very difficult for long term. Even only 5% or maybe 1% of people only can manage this thing, calorie intake or diet and exercise. This is not practical in the current scenario. So the surgical correction in the upper airway, in the presence of morbid obesity, is not accepted, because the main cause of OSA here is the severe obesity. So without correcting the root cause, it is futile to go for the only surgery in the neck. So all these procedures are being done in our center. So as sir told in the last case, after within 3 months, patient lost 22 kg, and patient had a complete resolution of diabetes and complete resolution of OSA, and he was on 2 drugs of for hypertension. Now it is reduced to one single drug, and maybe it may go completely at the end of 1 year or so. Patient is lost actually the 6 months, like up the 28 kgs something. So maybe one at the 1 year, he will lose like 60% of the excess weight. So this sleep study, this polysomnography before and after, this obviously there is weight loss is helping people to get rid of OSA. So there are all these studies. It is simple that if you get rid of obesity, the high degree of snoring or high degree of OSA is almost unknown in very thin people. That's what it's saying. If you give good quality of sleep, and everything will go. So in our series, we have done this Sastre bypass. This is a newer one. So we started like 2 3 years before. Uh, we are giving excellent results as good as bypass. So in this the one peculiar thing in Sastre bypass, that is single anastomosis sleeve jejunal bypass. So we have the access for the ERCP access. We have access to the normal biliary tree also. Suppose patient is having any CBD stone also, we can have access to get the stone through ERCP only. That is a big advantage of Sastre bypass over this OHGB or MGB or ROGB. So in those patients, we cannot have access. The normal access is we cannot reach the pylorus or we cannot reach the D1, D2. Maybe special scopes with the long enteroscopes are available in special centers only. We can do RCP. This is a very good advantage in Sastre bypass. So in this after the surgery, the Sastre bypass, the single anastomosis sleeve jejunal bypass. Uh, so so after 3 months, what happens? The food it won't go to the pylorus in the normal natural way. So the foregut will be completely bypassed and food will go to the jejunum. It is bypassed like almost 180 centimeter. That is one third of the intestine. Suppose the intestine total in bowel length is like 6 meters. It is almost one third is bypassed, and because of foregut exclusion, the all incretins, all this GLP-1 and GAP hormones are increased. Like you are injecting this Wegovy, all Ozempic, all this Mounjaro continuously. So that is already set because of the discovery. First, because of that cancer stomach, they did gastrectomy and they did Roux-en-Y bypass or GJ bypass. So through that, they discovered patient the diabetes is gone. Then the Poris, he found out. First, they did surgery in 1995 itself. They published in that article. So after doing RYGB, that is the procedure first came like as a metabolic procedure in 1995 itself. That is causing a diabetic reversal, and also not only diabetes, all YSA, hypertension, dyslipidemia, everything gone in one single surgery. And later on this sleeve came, later on this MGB OHGB came now, and the new kid in our block is this SASJ. So that is giving excellent results. So we have this biliary access also. Patient is tolerating very well. Thank you.
Yeah, sir, it was very great.
Hello.
Sir, now I'm going to take a question, sir, one by
Yes.
one.
Yes.
Okay. For you, sir, like I can see the question is, what is
Yeah.
the typical timeline for improvement in OSA symptoms after bariatric surgery, sir?
I couldn't get you. What is the exact question? Typical
Uh,
timeline?
Sir, what is the typical timeline for improvement in OSA symptoms after bariatric surgery?
Yeah, see, the patient loses significant amount of weight loss. That is, maybe 3 to 6 months. They get rid of this OSA, but not all the patients. We are not doing the sleep study after the surgery because they are feeling better. They are very active in during their daytime activities. So we are not doing sleep study in all the patients. except for our study purpose only we are doing in select cases only. But other than that, they are improving after losing some 20 to 30 kg. They always get reversed.
Okay, sir.
But diabetic
Thank you for
reversal,
the answer, sir.
but diabetic reversal is happening like within 1 month. Within 1 month, patient can lose only like 10 to 12 kg only. But even before losing much weight, also the diabetic reversal happens because of incretin secretion.
Okay, sir. Thank you for the answer, sir. We are taking another question, sir. Can
Yeah,
I take?
yeah, please.
Okay. So the question is bariatric surgery a cure for OSA or a long-term management tool?
Yeah, see, so obviously, see, okay, a patient is like morbid obesity, like BMI is 45, like 120 kg. So, if you are doing for this UPPP, that is uvulopalatopharyngoplasty, for that patient, so it will result in failure only. So but by doing the bariatric surgery or metabolic surgery, you are removing like 40 to 50 kg in like 1 year. Patient will definitely get the permanent solution for OSA. But there may be some patients after 2 years there is a slight chance of weight gain, so they have to follow up. And they will go in a wrong way. They'll be eating some wrong food, or they're not exercising as much. So at the time they may regain some weight, but not to the extent of causing OSA. So it's almost OSA resolution is almost complete in post bariatric patients. Yeah, that weight gain is like around maybe 10 kg. So but that won't cause the comeback of OSA. That's not happening. Hello.
Okay, sir. Thank you for the answer, sir.
Yeah,
Sir, I want to take another two questions
yeah,
from Rajkumar, sir. He
yeah.
said,
I will answer on behalf of him. Yeah.
yeah.
Hello. Please go ahead. Hello. No, no, no. You can go ahead. Questions. I will answer on behalf of him.
Okay. Okay. Sir, the question is, yeah.
Yeah.
So the question is, how sustainable is diabetes reversal? Do
Yeah.
most patients relapse, and after how long?
Yeah. See, the only see the relapse is very less, because the timing of metabolic surgery is very crucial. And the C-peptide levels, that is the pancreatic reserve at the time of surgery, that is also crucial. If the patient is very good functioning pancreas, so they will sustain the resolution of diabetes in bariatric surgery. So suppose after 10 years, the C-peptide levels are almost okay. It is not high. It is like manageable levels. Patient may go for relapse. We are saying that like that. But if the patient is having very good C-peptide level, the surgery is done like within 5 years of onset of diabetes. We can accept complete resolution, because the procedure like SASJ or OHGB or ROGB, the foregut is completely bypassed. So the patient is getting continuous influx of the incretin, like that GLP-1 or GIP. That means we are giving endogenously GLP-1 endogenous. We are giving like Manjaro or Ozempic or Wegovy. We are giving continuously. So that effect is sustaining, because the system inside it is like that. So it is always that G hormones incretins are always high. So insulin resistance is not coming back, and the relapse is very less, unless if we do surgery on the edge of like after 10 years of diabetes in those patients. And we can see the relapse of diabetes in lack of follow-up. If there is lack of follow-up and patient gained a lot of weight and they didn't come for follow-up, we are seeing some relapse.
Okay, sir.
Okay.
Now we thank you for the answer.
Okay.
Now we have one last question, sir.
Okay.
Can I please?
Please, please proceed.
Sir, the question is, uh, what gaps in research need to be addressed to establish reversal as a standard of care?
Yeah. How to address this gap?
Yeah,
Yeah. See, it is all our responsibility of the medical fraternity. See, the central theme for the insulin resistance is the central obesity. Why patients are developing the most of the type 2 patients are obese only. Very few patients are only very thin built. So that their mechanism is different. So the majority of patients are obese. So it is the duty of physicians. We have to ensure to come back to normalcy of weight. So then the chance of a resolution of diabetes is very high. Suppose this patient is like newly onset, newly detected type 2 diabetes with a 10 kg excess. See, patient doesn't need a metabolic surgery or bariatric surgery. He just lose another 10 to 15 kg by either diet and exercise or tablets or Manjura or Vigovi, like this stuff. So once they reach the normal weight, obviously we can see the resolution of diabetes. But these kind of teachings, this kind of explanation, it's not happening at the physician's level. So we fail to educate the patients that you just lose the weight and your diabetes will get reversed. So that is the first we have to address the public, or we have to address the physician. So we have to insist the patients that they should lose the excess weight aggressively, and they have to maintain. See, that maintenance is the problem. That's where the surgery comes in. It is easy to maintain a post bariatric patients to sustain a certain weight, but rather than a person losing weight by exercise and diet. So if they lose motivation or something, they will gain weight and again they will become diabetic. So we have to address the central obesity and the higher waist circumference. These individuals, we have to address the metabolic syndrome. This is a syndrome. It's a very conglomerate of all OSA, hypertension, dyslipidemia, and insulin resistance. We have to target this by reducing the waist circumference by losing more weight. So we have to insist on this factor to the patients. And if they're not losing weight by either any exercise or this thing, they should not lose time. So suppose patient is diabetic by the age of 40. So they can wait maybe like another 5 years. Up to 45, they can wait till the time they have to lose weight. After that, you cannot go for bariatric after 15 years of diabetes, even though they are obese. You can do surgery, but they will lose weight. But already there will be end organ damage, damages are happened. So already pancreas is burned out. So they cannot, we cannot have a diabetic resolution in that setup of after 15 years. So the teaching will be the both the physician level at the patient level also. Hello.
okay.
Yeah.
So, yeah, thank you for the answer, sir.
Okay. Thank
I
you.
hope you did justice with the presentation and answer.
Okay. Thank you.
So,
Thank you
with
for the
all the
opportunity.
information, can I conclude the session?
Yeah. Please.
Sir, and thank you once again, sir, you sharing your expertise and valuable perspectives.
Okay. Thank you.
With all
Thank you.
your permission, I am concluding this session.
Yeah. Thank you. Thank you very much.
Thank you, sir.
Okay.